Hi, everyone. Thank you so much for joining us today. I think everybody has joined. Welcome to our last GeroECHO session from our cognitive impairment series. This session will be focusing on what matters most, and we'll be focusing on major transitions, end of life care, and respecting your patient's life goals. I know it's been a crazy busy week for everybody. With the elections, COVID ramping up in a lot of states, I know. So we definitely thank you for taking your time and joining us today for this session. Happy Friday, everybody. As you have seen in our last few sessions, we're going to follow the same structure with a welcome and announcements and introductions, followed by a quick 20-minute didactic led by MP Camille Fitzpatrick. And then we'll move on to our case presentation presented by MP Nicole Vidal with collaborative discussion about the case with everyone here today, ending with closing and reminders. As you all know, we are CME accredited. Our main objective is to educate community and rural healthcare providers in age-friendly geriatric patient care, treatment and management, and to expand access to geriatric specialty care throughout California and beyond. Our target audience is you all and anyone with an interest in the care of older adults. Today's session is accredited for 1 CME, and if you have been attending all of our sessions, this is our 5th session, so you should have received 5 CME credits. House rules, please be sure to mute yourself when you're not speaking to prevent background noise. Always introduce yourself with your name and location, and maintain confidentiality and HIPAA at all times. Just to let you know, this session is being recorded, and your participation confirms your consent to this recording. We are a grant-funded program by the Health Resources and Services Administration, and this information or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. None of our faculty members have any financial disclosures at this time. So we'll go ahead and move on to our introductions as we have done the past few sessions. With a name, site, and location. So my name is Nika Seville, and I'm the grant manager here at the UCI Division of Geriatric Medicine and Gerontology here in Orange, California. So we'll go ahead and move on to the rest of our HUB team. Whoever would like to go first, go ahead.
I'm Dr. Sonia Sagel. I'm a clinical professor at UC Irvine Division of Geriatric Medicine. Welcome, everyone.
Hi, Lisa Gibbs here, Chief of the Division of Geriatrics. Great to have you here. Thank you.
This is Camille Fitzpatrick. I'm a geriatric nurse practitioner, and I work at the Santa Ana Family Medicine Clinic in Santa Ana.
Hi, I'm Dr. Gurevich. I'm a clinical pharmacist. I work at UCI Senior Health Center, and I teach at USC School of Pharmacy.
Hi, I'm Norm Wall, and I'm a geriatrician up in the Napa Valley, California.
I think that's our hub, so we can go ahead and move on to our attendees and spokes.
Hi, this is Dr. Kan Wen from Kaiser Orange County. I need to make a quick apology because I will have to leave our meeting a little bit early today for a clinic administration meeting. Just want to take the opportunity to thank everyone at UCI for what has been a wonderful learning opportunity for me. Thank you.
Thank you, Dr. Nguyen, and I'll be sure to send you the slides afterwards.
Thank you.
Hi, this is Ann Ellett, nurse practitioner here in Orange County, private practice. And I also would like to really thank the UCI team. You guys have been great, and I've looked forward to these in this time of isolation. So it's been a great experience.
Thank you, Ann.
My name is Nicole Vidal. I'm a nurse practitioner here at UCI with our ACO team.
Thank you, Nicole. Happy to have you.
Hey everyone, my name is Tali and I'm one of the pharmacy residents from USC, and I'm rotating through the UCI Geriatrics Clinic right now.
Thank you.
Hi,
Anyone else on the line?
everyone. My name is Austin. I'm a fourth-year pharmacy student at the USC School of Pharmacy, finishing up a rotation at the my AmCare rotation at the UCI Senior Health Clinic.
Thank you, Austin.
Hi, good afternoon, everyone. My name is Beatrice Vidas. I'm a nurse with the UCI Mind team on the campus in Irvine, UCI campus in Irvine. And I will be starting as an NP postgrad student in January. And I thank you guys for letting me join this group.
Thank you.
Hi, my name is June. I'm a fourth-year pharmacy student as well, working with Dr. Gurvich doing my AmCare rotation here at UC Irvine.
Thank you.
My name is Grace. I'm also a fourth-year pharmacy student at USC School of Pharmacy, finishing up my rotation with Dr. Gurvich for AmCare.
Hi, I'm Kat Dazenbu. I'm one of the current geriatric medicine fellows at UCI. So it's a pleasure being on with you guys today.
Anyone else? Okay, I think we can go ahead and move on into our didactic presentation. Camille Fitzpatrick, who is one of our clinical professors and NPs at our Family Health Center here at UCI. Camille, take it away.
Okay, am I unmuted?
Yes, we can hear you.
Perfect, okay. Well, welcome everybody to our final session, and thank you to Nika for all you have done. Today's presentation, next slide, is, as you know, what matters most. And I always begin my presentations to any audience with a quote. And this quote I thought was pretty apropos. Life is unpredictable. It changes with the seasons. Even your coldest winter happens for the best of reasons. And though it feels eternal, like all you'll ever do is freeze, I promise spring is coming, and with it brings new leaves. I got this quote from Maria Shriver's Sunday newsletter, which I have put a resource at the end. Wonderful, wonderful positive thinking for this time of life and any others. Next slide, please. So we'll start off with major transitions. Obviously, 2020 has been a year like no other, with many transitions. I think we're still in the transition of the election. I really don't know what's going on right now, nor does anybody else. But also transitions, it's been a year of loss and sadness, but also opportunity and new learning. For me, the year started with the death of my mother, January 2nd. February 20th, I had a neck injury which stopped my running and my life cold. In March, we were all on lockdown from COVID. March 23rd, my oldest brother died. July 10th, a good friend who was 32 died. And 2 weeks ago, another friend died. So I'm hoping you're going to permit me to speak from my heart with personal experiences to show how they relate to this final topic of what matters most. I may leave you, though, I have to warn you, with more questions than answers. Next slide, please. So these are my parents. They were married at the age of 21 for 61 years. They were devoted to each other, held hands wherever they went. Everybody knew that they loved each other. They lived on Cape Cod, and they were devout Catholics, which is important. Next slide, please. So this is the family. My mother, who we're going to really be speaking of as the case, had 8 children, 5 girls and 3 boys. She was the matriarch of our extended family. Holidays and birthdays were always at her house with lots of Italian cooking. She was active with her lady friends and the church, of course. All was wonderful until my father got cancer. She never thought he would die before her, and she was just not going to allow it. She refused to place him on hospice, and when he could no longer stand the pain, he told my sister he was ready and to take him to the hospital, where he received morphine over 4th of July weekend and died. My mother blamed herself for allowing the doctor to give him the morphine, which she felt killed him. She never stopped grieving my father's death and began stopping some of her usual social activities. She developed pretty significant osteoarthritis in her neck, her hands, her shoulders, and her knees, and was in a great deal of pain. She never really liked exercising, but had walked daily with my father, but stopped after he died. And without exercise, her pain worsened. The daughters encouraged her to walk and socialize, and she would agree, but then she'd not do it. She had always had insomnia, and now that worsened. Her doctors put her on antidepressants, sleep meds, NSAIDs, Tylenol with codeine. She developed hypertension and osteoporosis with compression fractures. She also had urinary incontinence. All resulted in more medications with no resolution of her conditions. She then developed multiple episodes of pneumonia, many resulting in hospitalizations followed by stays in a rehab or SNF. She began falling, as you would expect. She had many falls, some had hospitalizations and rehab. The family urged her to sell the big house, move to a community or assisted living. She would have no part of it because that's where she and my father lived, and she was not moving, ever. Then the big fall happened. I called her regularly, and sometimes she just didn't answer the phone, but this particular time she didn't answer any of my multiple calls over 2 days. I then checked with various sisters who also had not talked to her despite their calling. I urged one of the sisters to go over, and by the time she got there, my mother had been on the floor for 2 days, covered in urine and feces and unable to get up. She was hospitalized with rhabdo and pneumonia and miraculously had no broken bones. None of the children thought she would live, but she had excellent care and sheer determination. My mother was discharged after 6 weeks in rehab. The family pressure grew fiercer and my sisters started taking her to look at assisted living facilities. Mother, of course, was pacifying everyone because she had no intention to move. She did, however, to agree to having a caregiver 3 hours a day, 3 days a week. However, she either fired the caregivers or told them not to come back because they just sat around and did nothing, and she preferred to be alone. She sometimes would slur her words or repeat herself during conversations, and we questioned her cognitive capacity. Was she cognitively declining? Was she not eating or drinking? Did she stop her medicines again? Or did she take too many? She frequently would just say, "I just want to die. Why won't God take me?" The falls continued. Some we knew about, others she hid from the family. She also continued with repeated pneumonias. Family discussions continued as to what to do with her. And we asked her doctor to say she was not able to make good decisions and safely live by herself. He tried to convince her to get more help or move, but he said she was able to make her own decisions and he had no control over her life. She was now telling the family if she fell or developed pneumonia again, she did not want to go to the ED or be hospitalized. There were many paramedic visits, one during one of my visits, actually. I heard a clunk in the middle of the night and ran downstairs to find her on the floor. I could not pick her up by myself, so she reluctantly agreed to my calling them. They put her back to bed, and she was furious with me for telling my sisters. The final decline came after my last visit. Although my mother knew my oldest brother had cancer, she had not physically seen him. They talked regularly on the phone, but because she couldn't drive, there were no actual face-to-face visits. I, of course, when I went back there, took her to see him. When she saw him, the color of her face drained and she became quiet. When we left, She said, "He looks just like your father did." From that point on, she insisted she was not to be hospitalized and she would not allow her son to die before her. Next slide, please. So these are various transitions. With any of our older adults, or certainly our patients who have cognitive impairment, and with my mother, the question comes, when can they stay with living home alone? Is it time to go to a retirement community and downsize? Should we move in with the family? All of these we talked about with my mother. Should they stay at home with assistance, a little assistance, more assistance, and then really a lot of assistance? Do they move to assisted living with more assistance? And then not for my parents or my mom, but for some of our other patients, there's board and care, there's dementia units. And finally, this home again with hospice. Next slide, please. So, how do we respect our patients' goals? Who knows best? When we decide what's best for our patients, what happens to them? There's huge guilt over placements. These are life-altering decisions. What do we value the most? What do our families, our parents, our patients value the most? Is it how long they live? Is it can they function, the quality of life? Is it autonomy, but a shorter life? Gawande talks about his mother-in-law and his father, actually, who were very independent people. They lived as long as they could by themselves, and then various disasters started to happen. Again, cognitive issues or falling. Eventually, both ended up not living at home. Once they were finally placed, they shortly died thereafter. So how often do we really see this? Next slide, please. Being afraid of dying is normal, right? But particularly in our culture, death's viewed as a thief or the one robber and villain that we can't really fight and win. There's really nothing we can do about it. But does it have to be so scary? Is there a natural way to approach the end of life? It is natural. Dying is natural. And how can we view it as the circle of life? So I'm hoping that potentially you folks had a chance to look at the website that Nika sent earlier this week. Thank you to Ann Ellett, who writes a wonderful newsletter called Memory Care Support. And if this time, potentially she can tell you about what she does with dementia care. But this website and this article and recording talked about nuns who were not afraid of dying, who viewed it as natural, who viewed aging and the transitions in life as just that, transitions in life, and they were so graceful about it. Next slide, please. So, as you can see, this was a bad and a final fall. Last Christmas, as much as my mother could not really do very much, she was still the elegant lady, and she wanted to make my youngest brother and his family some Christmas dessert. So she unsuccessfully went to her dining room, reached for her finest dishes, didn't quite make it, and she fell. So this was her final fall. She obviously was rushed to the hospital. She really didn't have much to say about it. When she got there, she had pneumonia, she had a concussion, she had severe dehydration, and miracle of miracles, I guess, she had no actual fractures. She was in pain, obviously, and she had pneumonia, as I said, and there were many antibiotics tried and fluids and so forth. But mother refused to eat. And the doctor said to her, and the family said to her, "Mother, you have to eat. If you don't eat, you're going to not be able to sustain." Anyway, she refused. And the doctor said, "Well, I can give her, I can keep her alive. We can keep trying." But we have one sister who actually was the power of attorney. She was the person who gets to decide with the advance directives. And she talked it over to the family and she said, "Mother said she didn't want to live. We may be able to continue. I think we need to stop." Well, you can imagine what happens in a family of 8. There's never going to be any consensus, but she had the final say. And it stopped. Next slide, please. So, end of life care. Should we have done more? What do you think about feeding tubes? If the patient has the ability to make the decisions and they've made their advance directives, don't they have the right to decide? Could this have been better? Could we have tried to convince her more vehemently about hospice? Should we have continued? My sisters were with my mother around the clock for her last 48 hours. At the very end, one of my sisters, while holding her hand, saying to her, "Let there be peace on earth." Let there be peace on earth. When she finished, my mother stopped breathing and she transitioned. Is there a way we can view the end of life with less sadness and anger and denial? Can we remember the joyful times? Next slide. And the next slide.
Thank you so much, Camille, for your presentation. That was a very difficult subject matter. I was wondering if any closing statements or any questions for Camille.
This is Ann Ellett, and again, thank you, Camille, because stories are so important, I believe. But to me, you asked two really important questions. Who knows best? And what do we value the most? And I think those are questions. I mean, I work specifically with people living with dementia, but I think those are questions we should all be asking our older clients and helping them with this. And your mom was beautifully clear about what was important to her, that she have control and do it her way. But I, so often from the medical approach, I think we forget to just pause and ask those questions that I think are so important.
This is
Thank you,
Dr.
ma'am.
Nguyen. I also wanted to thanks Camille for such a powerful story, personal story that you share. Make me feel that I'm not alone in the difficult decision that we make, not only as clinician, but also personally in our family's life. So again, Camille, thank you very much.
Thank you.
Thank you so much, Camille. Any other questions or thoughts that you'd like to share, audience or our hub team?
I wanted to share, so I used to do a lot of long-term care. So as a pharmacist, you would go into a long-term care facility once a month to do a medication review. And every once in a while, I would walk into a patient's room. And this one patient, this happened maybe 20 years ago, and I still remember this. This was a woman, you walk into a room and there were all these pictures of her as a young woman. She was a beauty queen.
Oh.
And gorgeous face, gorgeous body, and they were plastered all over her little room. This woman now was in her 90s. She was shriveled, and she had a feeding tube in. And I talked to the nurses about her, and it turned out that the family maybe visited once every couple of weeks. She was basically alone with this feeding tube. And she, she was grimacing and just did not look happy. And I wondered, like, it struck me then, and I still remember it now, like, what's the point? She was this beautiful, lovely person, and I'm sure she had a really full life, but dying slowly in a nursing home with a feeding tube just didn't seem like this is the kind of person who would have wanted that. So I just wanted to share that.
Well, and I think that's a great illustration of the role that all of us health professionals can play. Somebody had to write the order for that feeding tube.
Right.
And again, maybe without asking those questions, who knows best? What do we value? What does she value? Someone had to write that order, and then probably walked away and had very little contact with her and didn't see the quality of her life. And that's always the basis of what we need to ask ourselves, is the quality of their life.
This is Beatrice. Thank you so much, Camille, for sharing that with the group. I know that your story brought back episodes where I struggled with decisions like that for my family. So thank you for sharing, and I hope that this can become a discussion that's more open, because I think it is really important as our population grows older, and we have so many older adults that are being hospitalized for a long period of time. I think we really do need to encourage these conversations to be a regular part of wellness checks and healthcare visits. So thank you for holding this topic.
Thank you so much. And I know that IHI has a toolkit on the kinds of questions that you can ask. Like I can also share it with you all when I send my follow-up emails as well, if you guys want to access their toolkit as well. Anything else before we move on into our case? Okay, thank you so much, Camille. This was such an amazing didactic and to close out our last session, so thank you so much. So our case presentation is going to be led by Nicole Vidal. She is one of our MPs here at UCI. And so I will go ahead and share the case so she can give you our overview. 1 second, please. Can everybody see this?
Yes.
Can everybody see the case?
Yes.
Okay, wonderful. Okay, Nicole, you can go ahead and give us your summary of this case.
Okay, everyone. So again, my name is Nicole. I work here at UCI in our ACO, and I work with a lot of high-risk seniors. So we're going having discussions about transitions of care and advanced care planning. So this has kind of been a challenging case for our team, and I think it kind of goes along well with Camille's presentation on whose opinion matters and how do we value our patients and their families' desires and wishes, but at the same time, how do we help them to make the best decision for the patient? So this gentleman's 80 years old. I've been involved in his case for a little over a year now, and when he first came to my attention, he wasn't doing well at all. He was very malnourished, having frequent hospital stays. He's been hospitalized about 10 times since the beginning of 2019, actually. And so that's kind of how he was brought to our attention. At the time, he was receiving mainly specialty care with us and seeing nephrology and GI or colorectal surgery, but his PCP was outside of our system. So his history includes atrial fibrillation, stroke, and he was on peritoneal dialysis. So his main thing that kept taking him to the hospital was he continued to have chronic diarrhea. He'd become dehydrated. He would have syncopal episodes because he would become orthostatic, and every time he'd go to the bathroom, he'd basically pass out, prompting his family to call 911, and he'd be going to the hospital for evaluation. He'd be found to be very dehydrated. He'd have electrolyte imbalances, and he just overall was not doing well. No one could figure out why he kept having this chronic diarrhea. Because he was at the time with an outside PCP, it was really hard to collaborate in his care and get him the specialty care he needed. He wasn't very verbal. The patient himself was just very somnolent whenever we would see him. He would make noises but not really respond to questions. And his son was the main historian. He did live at home with his wife, and his son lived nearby, but not with the patient. So the patient's feral wife was the only person there to take care of him. And so we were able to assist the son with getting a geriatric consult, and that seemed to help a lot because we were finally able to help get him to GI and get him a little bit more aggressive treatment. So when he came in to establish care, he was actually hypotensive and really dehydrated at that time, but he seemed to improve with some parenteral hydration. So for a while, he showed improvement, and then he declined again. He did finally get into GI about 6 months after I first met him, but still very malnourished, not taking in a lot orally, still having recurrent hospitalizations, lack of appetite, didn't want to eat. So he's tried on oral appetite stimulants that didn't seem to show much improvement, and the dose was titrated up. As of April of this year, hospice and comfort care has been discussed with the family, but the family wants to be more aggressive with medical treatment. They opted to try an alternate appetite stimulant and were advised that if it didn't work, then the next option would be a PEG tube and to switch from peritoneal dialysis to hemodialysis. Recently, he was actually hospitalized again with a pneumonia and placed on a ventilator. He was weaned off of it, but not for very long. And the son has notified us that they're talking about performing a tracheotomy. When we tried to broach the topic of advanced care planning and the patient's wishes, the son was reluctant to discuss any kind of advanced planning due to being actually devout Catholics as well. So it's been really challenging. It's been hard as a provider to watch him deteriorate despite such aggressive treatment, but at the same time to respect the patient and family's wishes. And honestly, it's really unclear what the actual patient's wishes are because he is so limited with his verbalization. So I just thought that I would bring this to the group for discussion on maybe either how other ways to approach the patient and family with regards to discussing realistic goals of care, or as a provider to change my mindset and learn how to accept the aggressive treatment that doesn't seem to be working.
Thank you so much, Nicole. Okay, does anybody have any discussion? To our spokes or our hub team?
This is Beatrice. Have we tried it all, or have you tried it all having, gosh, I can't remember the correct term, but like a clergy discuss like long-term or advanced healthcare directives or advanced planning, maybe hearing it from someone of the same religious beliefs or who can better understand religious beliefs kind of in an unbiased fashion, who's not providing care, might be able to just provide the right things to say, for lack of a better term.
Sorry, I just needed, no, but that's a good idea. I didn't think to have someone of the religious faith discuss it with them.
This is also a really good opportunity to kind of deprescribe and get rid of anything that's not absolutely essential, because a lot of these symptoms, yeah, that's a pretty extensive list.
Yeah, he's on a pretty long list of medications.
So yeah, I mean, I'm just kind of looking at like Crestor, really? Like, so, I mean, I'm looking at this med list like very briefly, and I could see things that could certainly be discontinued that might actually make him feel better.
Yeah.
You know, less orthostatic, or, you know, less stomach pain, or whatever is making him uncomfortable.
Yeah, that's a really fantastic idea. Unless the family would equate deprescribing with, you know, giving up. I think that's one sort of psychological barrier. that needs to be discussed. But completely agree with you.
Well, ideally, deprescribing sort of involves the family and kind of it's a plan. It's not to, it's, it's not just,
Right.
you know what I mean? I mean, like you have to
Oh,
present it
totally.
the right way.
Yeah, totally. It's like you have to present, that it's not less care, it's better care.
Right, exactly. That's exactly how to do it.
Well, thank you for bringing this case. I just had a question regarding the patient's spouse and what her thoughts were about the situation and the son's involvement and because she had known the patient, I'm presuming for many years, and maybe something was discussed between the both of them regarding his wishes.
Yeah, the spouse is pretty hands-off in his medical care, and there is a language barrier, but we've used an interpreter, and she kind of just defers all decisions to the son, who actually I think makes it more complicated that he's also in medicine. So that's another layer of challenge, but yeah, the wife doesn't seem to get involved very much.
Thank you. Can I ask one other question, actually? Or one thought is maybe approaching the son, maybe just trying to understand where his motivation is for trying to be very aggressive with the patient. Does he, what's his understanding of end of life care? I don't know the background of this healthcare professional, but is it something that he's familiar with? Maybe he needs a little he needs a little education about it. And just kind of understanding, is there guilt? Is there fear? What the son's emotions are about this process.
I think, yeah, that's a great suggestion too.
It's Beatrice again. I was wondering, I did a couple of rotations through UCI Health while I was getting my MSN. I know while patients are inpatient, they have access to, or you can order a palliative care referral. Is that something that you can do as an outpatient, on an outpatient basis? Like a palliative care conference with the family?
So
what I've seen from outpatient, go ahead.
Oh, sorry. You can order a palliative care consult, and the patient could go to the clinic with the son and the spouse or whoever else, and he can have a consult with palliative care, and so that would be one approach.
What I've seen from outpatient palliative is more symptom management for people with multiple complex conditions. So I'm not sure that they would really broach the topic of end of life care as much as an inpatient palliative consult might.
And is has the PCP been approached regarding what are the
the primary is very involved, and I think he's also tried to explain the prognosis and the different treatment options, the risks and benefits. It's just really hard for me to imagine this poor frail man who's already having so many frequent hospitalizations now get possibly a tracheotomy at 80 and potentially receive no benefit from that. So yeah, I mean, I guess ultimately what I've had to come to terms with is when it's the patient's time, it's his time, and no matter what we do to keep him going, like his body can eventually fail on its own despite all our measures. It's just, I don't know, that just seems like such a terrible quality of life to me.
Mm-hmm.
Any other questions or feedback for Nicole?
I mean, I don't know if it would help, but I'm happy to meet with the son on Zoom or whatever and review the meds and just kind of explain risk versus benefit and with him if that would help. I don't know if it would, but I'm happy to do that.
Possibly. I think I'm going to reach out to him after this call because I'm sure, I think I heard he had a discussion with the primary again today. So I might try to figure out if anything changed after that discussion and implement some of these recommendations as needed. But yeah, I can definitely have him scheduled to talk with you if you want to.
This is Beatrice again. I think one of the things that I maybe would like to, if anybody can chime in, is the second part to Nicole's question about kind of removing your own feelings and your own thoughts about how you think that patient should be cared for or treated. It's really hard to do when there's an emotional attachment or some kind of emotion attached to a treatment plan. How would you, this is open to any of you clinicians, how do you remove yourself from that, or how do you remove your own bias to a family's wishes?
Well, I mean, I'm sure there's other people will speak, but I always try to revert to like motivational interviewing concepts. So that, you know, then I'm not really put in a position of introducing my own opinion. You know, I mean, if and that usually works because obviously we want to draw out of them like what they're thinking and why they're thinking and, you know, what would need to change in order for them to make a different type of decision. You know, if they ask me my opinion, you know, very directly, you know, then I will tell them, you know, well, if this was my family, this is what I would likely do. But I think you're talking about more about the situation where the family is just, you know, really firmly deciding on, you know, an approach that you don't agree with as a provider, right?
Yes, exactly.
Mm-hmm. I'm not sure there's an easy answer to that, other than just, you know, maintaining consistency and support and being accessible and explaining why, you know, why there are different options and one option may be better than another. But Dr. Segal, you've done a lot of work in breaking bad news and and so forth. What would you say?
Yeah, I think, you know, in situations where you have a long-standing relationship with a patient and you've cared for them for many years, it can be very challenging. And like Dr. Gibbs said, I try to be as honest with families and patients as I try to be as honest and direct as I can regarding treatment plans and pros and cons of different options. And then in terms of managing my own emotions about a situation, I think if you're a clinician who cares about your patients deeply, I'm not sure that there would ever be an instance where we're not impacted. You know, where we celebrate with our patients, and we share sadness with our patients and grieve with our patients. And I think that's part of, you know, the honor of caring for someone. And I think, you know, so I don't know. I like Dr. Gibbs said, I don't have an answer for how I can't separate. I don't think any one of us could separate ourselves completely, but it's important. Self-care is important, and really, I think if it gets to the point where you're really affected, checking your own personal and professional boundaries and making sure that your own decision making and feelings for a patient aren't clouding or impacting yourself, your own health, or how you manage that patient. But you know, I think we're human and we feel.
Thank you both, Dr. Gibbs and Dr. Sagal. I really appreciate that. You both sharing your points of views, because it can be a challenge sometimes. Like you said, we're humans. It's hard not to attach yourself emotionally to someone that you've known for a long time, and especially if you care for that person, even though it's just a patient-clinician type relationship. Thank you.
Right. Yeah, and I always try to also remember that, you know, they're making a decision which directly impacts their life, and they may not be ready emotionally to make decisions that they have to make. Like, it might be hard to let go. They just might not be able to be that objective themselves. So I think just understanding that from an empathic, compassionate, you know, place also helps as well.
That is absolutely, that is so important, I think, because as a provider, as a clinician, you might see the writing on the wall. You know where this is going and where this is heading. But like Dr. Gibbs said, you know, I think it takes time for a decision maker or a family member to get to that point. And that's where your relationship with the patient and the trust that you've developed with them, I think can go a long way, as long as you kind of walk that process with them.
Thank you so much, Nicole, and everybody else who had something to say about her case. Any last quick closing comments before we move on?
I just wanted to say thank you to Camille for sharing such a beautiful story about her mother and her family. So I really appreciate that, and I know it was difficult. And I wanted to thank Nicole for bringing such a interesting and relevant case.
Thank you so much. So just to close this series out, and thank you so much for sticking with us for the last 5 sessions. We do have a lot of other education. I know our didactics were quick and short and sweet, with a lot of great information, but we do have a lot of other trainings and CME opportunities for you all if you want more information on things like the annual wellness visit, pain management, functional assessment. I know we did have a question about driving safety for older adults, so we do have a YouTube video and training that goes into that in detail. And our website does have a lot of other education and CMEs that cover elder abuse, caregiving issues, and long-term care. So I will be sending this to everybody, so you do have access to those additional educational opportunities. We will go ahead and send out our CME survey. So if you do want to receive CME, please be sure to fill out this survey. You will receive your CME or HP certificate about in a month. And then we are going to send out a certificate of completion to everybody who's been attending these sessions. So do be on the lookout. You'll receive that via the email you provided when you registered for the series. And then we just want to tell you a little bit about our next upcoming age-friendly GeroECHO series, which is going to be focusing on mental health. We are still deciding on when we want to launch that because we do want your feedback first to make sure that we pick a time where people can actually attend, whether it's going to be before the holidays or after the holidays, and what day of the week, what time of the week is best for you all, because we do hope that you will be attending again with us. So I know Dr. Gibbs wanted to give a little bit of a quick overview of what the mental health series is going to cover.
Thank you. Thank you, Nika. Yes, so we're very excited about the mental health series. We thought it was very appropriate and timely given the COVID epidemic and pandemic, and really the ramifications, of it for our patients, meaning, increased isolation, anxiety, depression, and their effects on their cognition as well. I really saw a patient yesterday in clinic who'd been isolated in an assisted living, and without regular stimulation, her cognition had just really declined until her daughter pulled her out. So we will be discussing mental health, and we will be attaching that and associating it with the 4 M's. So mental health as it relates to mentation, then mobility, even pharmacy, and what matters most. So please, if you enjoyed this and you can make it, look out for Nika's emails, and we would love to have everyone join us for our next series.
Thank you so much, Dr. Gibbs, and we hope you enjoyed the 5 sessions that we held. And if you have not been able to attend all of the sessions, we do have them recorded. So if you do want to watch them at a later date, we're happy to share those links with you all. And as Dr. Gibbs mentioned, please be on the lookout for our next email. We do want your feedback, so we will be sending a survey that will help us determine the best time for launch. So please be on the lookout for that, and have a wonderful weekend, everybody. I want to thank our hub team for attending every session and leading these sessions, and to all the attendees, thank you so much for the great conversation.
And Nika, thank you so much for running this so smoothly and launching this and being available to everyone.
Of course, thank you so much. Happy to do it again, love it. Have a good weekend, everybody.
Bye.
Thank you so much, Camille and the hub. Bye.
Thank you, bye.
Thank you.
Thank you.